Val, do you have the ability to hover over Shane's three dots and make him a co-host?
Good afternoon, everyone. We are just waiting another minute or so to allow people in from the waiting room. Okay, I think we'll go ahead and get started since everyone has been generous with taking time out of their day, and folks can just continue to enter as they arrive. Good afternoon. My name is Valerie Resendez, and I am the Associate Director for the Adult Treatment and Recovery team here at BHA. And this is our agenda for today. We have a lot of great speakers, and we hope that if anyone has any questions, feel free to put them in the chat. But this is what we're going to discuss today. We've got introductions of our provider convening work team, an update on ASAM 4, gain assessments and JBBS facilities, and then care coordination for the involuntary civil service certifications programs. Next slide.
Welcome, everyone. I'm Jill Davis. I'm a program assistant for the Behavioral Health Administration, and today's ASL interpreters will be Jose Perales and Paul Villarreal. During the event, you can spotlight our ASL interpreters so they will appear larger on your screen. You have the ability to change your view at any time. In the upper right-hand corner of your screen is a view button. Use this to toggle between speaker view and gallery view. You can hover over the right corner of the ASL interpreter video and select pin if you would like to see them large on your screen. We are expecting a large audience, therefore everyone has been muted to reduce background noise. So make sure you're muted when you're not speaking. If you have a question throughout the presentation, you're welcome to use the chat or use Zoom's raise hand feature. And questions will be addressed by the chat moderator when appropriate. We'll have time in between each presentation for questions. If you do have an opportunity to speak, we kindly ask that you introduce yourself and your agency. And all links will be shared in the chat and any files at the end of the meeting. They will be available on the BHA website within 3 to 5 days, along with the recording of today's meeting. Thank you so much.
Good afternoon. I am, next slide, please. I am Webster Hendricks, the BHA Criminal Justice Team. And the BHA statewide programs team will be hosting this bi-monthly convening and discussing information and updates relating to provider services, and also providing opportunities for ongoing engagement and provider contributions. As noted, these meetings will be recorded and published on the website. Next slide, please. We want to remind those who are familiar and to update those who are new that the BHA mission is to co-create a people-first behavioral health system that meets the needs of all people in Colorado. We thank you for joining us in this effort. Valerie?
Thank you, Webster. I would like to introduce our BHA executive leadership team. I'm not sure if any are here today as KBC is occurring and PrEP is happening, but Smith is our commissioner. Aisha Russo is our chief strategic officer, and Kelly Causey is our deputy commissioner of children and youth. Next slide, please. And can everyone hear me okay? I understand that there was a little bit of choppiness. Michelle, okay, I will try to speak a little bit louder. I'd also like to introduce the statewide program directors and the provider convening team. And I see a few folks on, so if you are on the call, please jump in and give a quick introduction to yourself. Mark, I'll start with you.
Thanks. Good afternoon, everyone. Mark Conajani. I use he, him pronouns. I am the division director, and division titles changed a little bit. It's the adult behavioral health continuum, as we have updated our org chart to have a division that's laser focused on building out the adult continuum of services, and then one that will be focused on building out the continuum of services for children, youth, and families. So hi, everybody. Good to be here. Danielle or the others, give you a chance to say hello.
I'm on, I can do it. So I'm Heather Pash. Hello, I'm the Director of Care Coordination. I'm not sure if any of the other directors are on as well.
Okay, and then we have our provider convening team. I know Melissa and Shane and Jill and Webster are all on. I don't know if Samantha, Sammy, are you there? Would you like to say hello?
Hi, Val. This is Melissa. I'm Melissa Morales. I am the Adult Continuum Program Assistant, and Samantha is not in today. She's out sick.
Thank you. Shane, Jill, would you like to say hello?
Yeah, hello. I don't know, I'm having a little bit of a tech issue with my mic, so hopefully everyone can hear me, but yeah, glad to be here and look forward to.
Hi, everyone. Jill Davis, she, her pronouns. Happy to be here.
Great. Now I'd like to transition to Kayla Martin, who is our Director of Contracts and Procurement, and Kayla is going to give us an update on the BOSSOs.
All right, good afternoon, everyone. So I am Kayla Martin. I use she, her pronouns, and as Valerie said, I am the Director of Contracts and Procurement at BHA, and I am also lucky enough to be leading our transition to forming our behavioral health networks with Behavioral Health Administrative Service Organizations, or BOSSOs. Next slide. So we'll give a quick review of what BOSSOs are and sort of what their structure and function is. I will give an introduction to our BOSSO vendors who were selected through our recent request for proposals, and I will update everyone on the implementation timeline. Next slide. So BHA has two main functions in the behavioral health space. We have our licensing and regulatory arm, which licenses facilities and makes sure that they are operating in compliance with rule. And then we also have our contracting function, where BHA actually is also a purchaser, a funder of behavioral health services in Colorado. And currently we purchase mental health. On the left side, you see our graphic. Currently we purchase mental health services through what used to be designated as community mental health center providers. Now in a lot of cases, CMHC, that designation is morphing into comprehensive behavioral safety net providers. They're the ones that we're CMHCs are not the only comprehensives, but that's our just sort of making that connection for folks. BHA also contracts for crisis services, but by contracting with administrative service organizations, or ASOs, which are administrative organizations that then contract for a network of providers to provide our full spectrum of crisis services. So walk-in centers, crisis stabilization units, respite, sort of those different tiers of crisis engagements. And then we contract with managed service organizations for our substance use services. So much like in the crisis realm, they are administrative organizations that contract with a network of substance use providers to provide the full spectrum of substance use services that BHA contracts for. So lots of inpatient or outpatient treatment, residential treatment, recovery, those sort of areas. So if this seems like it's about 3 different systems doing something similar, that I would agree. So one of the main structural updates that the BOSO networks provide is that BHA will be contracting with behavioral health administrative service organizations that will provide the entire, they will contract with providers to provide the full network of safety net services. So that will include comprehensive providers. It will include essential providers. It will include providers outside of the safety net designations. And they'll be providing mental health, substance use, crisis services, and care coordination. So we're sort of getting rid of this old trifurcated model that was broken into pieces and really getting to streamline things under one network divided by regions of behavioral health administrative service organizations, or BOSOs. Next slide, please. So why have BOSOs? What are the benefits that this brings us? Answering the question to why doesn't BHA just do this ourselves? So why do we need these partners? So the really front of mind answer for me is that BOSOs are regional. There are 4 regions of Colorado that we've divided based on studying a lot of how people access care, what care is available in which regions, and how do people in real life travel to get their care. So we ended up with a regional map, which we'll show sort of in the middle of this presentation. And there's a western slope, sort of mountain region. There's our northern and eastern plains regions, and then the metro area is broken into sort of a west metro, Jefferson County, that sort of half of the metro area, and then an eastern half, which is Denver, Arapahoe, Douglas, that sort of grouping. So we'll get to see the map in a little bit, but by dividing up the services in this way, or the regions in this way, the behavioral, the BOSOs will be a lot more embedded in their regions. In the RFP process, we really focus on selecting vendors who had history and knowledge and real operating understanding of the unique features and needs of those communities. So we think, the more that care is tailored to where people really are in their lives, the more effective that care is going to be. And then also individuals will, now moving away from this system where we purchase things in all different ways with different leaders, depending on what part of the behavioral health continuum you were looking to treat. Now there will be one clear accountable party in the BOSOs that is responsible for all the full spectrum of behavioral health care. So that'll take out some of the struggles to navigate these different systems. And then the BOSOs will, by having a full range of the full, by having vision into the 3 main areas of behavioral health, our mental health, substance use, and crisis, they'll really be able to, the BOSOs will be able to drive continuous improvement in the quality of services because they will understand how all of these pieces are working together. Next slide, please. So the BHA's role in the BOSO system, this is how BHA is a partner to the BOSOs. We will provide structure and standards and guidance to the BOSOs as they build their regional networks. We will coordinate standards of care and set, yes, I think someone else in the chat can do that. But we will coordinate standards of care, set access and quality metrics, and address any system level roadblocks. We'll drive collaboration and coordination between the state agencies. So if the BOSSOs are running into something where the Department of Public Health and Environment really has, they lead a lot of our prevention work. So helping facilitate those connections. Of course, a huge partner is the Department of Healthcare Policy and Financing, HCPF, which runs our Medicaid system. So these are really important connection points that BHA can facilitate. So the BOSSOs are really keyed into providing the best care. And then we will support and respond to community voice and needs alongside the BOSSOs. Next slide. In turn, the BOSSO's key roles will be to, first and foremost, help individuals and families connect to behavioral health care and ensure timely access to service. So they are going to be building networks that, as to the best that our funding will allow, to really ensure that we have coverage for the behavioral health needs in each community, and then especially that the BOSSOs are able to help navigate that care. They will consolidate, like as I said, the substance use crisis and mental health services that we have in our current system. They will provide a continuum of behavioral health safety net services and care coordination through their networks of providers. And then they will interface and align with the RAIs, the Medicaid service organizations, that so that we are coordinating on care coordination and services for Medicaid members, and especially for the people who are sometimes on Medicaid and sometimes not on Medicaid. So we'll have a really open door to address that population. Next slide, please. So this is introducing our first BOSSOs. So after a long RFP process, in October, we announced the winners of our request for proposals. Rocky Mountain Health Plans is our winner for Region 1. They have worked and operated in this region for a very long time, decades and decades, and just had amazing community support for the work that they do. And then Signal Behavioral Health Network was the winner in the other 3 regions. So taking both the Northern and Eastern Plains regions and then the metro area regions. So again, Signal has partnered with BHA and worked in the behavioral health administrative area for a very long time, and has incredible relationships, incredible understanding of the needs and history and gaps and roadblocks for these communities. And we are just so excited to continue to partner with them as we build this sort of new generation of how we contract for care in the state. And then next slide. I am very proud to say that this graphic was created about 1.5 years ago, and we've never had to change it. We stayed on track the whole time. If anyone has worked on projects of this sort of system level, it is tricky to do that. But so how we got to where we are here, we're approaching dot number 4. So in August of 2023, we released a request for information that got input from all stakeholders. So we had a ton of response from current providers in the system, from current advocacy groups and trade organizations in the system. People receiving services responded, other state agencies responded, counties. So we really heard from people on like, what, if we're going to do this transformative work, what do we want to transform it to? So that very directly informed the development of our request for proposals. So what questions are we asking? How what weight are we giving to each of these questions? What's going into the contract? That request for proposals, or RFP, was released in spring of 2024. We selected our vendors in fall 2024, and in a few days here, we will be under our startup phase contracts with the BOSSOs, and network development will begin. So then we have our, this is all working towards launch on July 1st, 2025. So the networks, the BOSSOs will be forming their networks, contracting with providers for the full spectrum of behavioral health services, really starting, we have to get through our budget season to know exactly what the dollar amount we're working with is, but really by the end of February, those numbers really come to solidify. And really that's the period after March through June, where we're expecting that the providers will be, the BOSSOs will be really actively nailing down contracts with providers. I think that's my last slide. Hi, thank you. I want to check with the provider convening team to see how much time we have for questions. If we don't have a lot of time, then I'm happy to provide my email address as well, and I can answer questions offline.
I think we have time, a few minutes, maybe 5.
Okay. All right, well, I provided my email address if something pops up later, and I thank you for getting the opportunity to discuss this exciting project with you all.
Great. Thank you so much
Thank
for
you.
that great update, Kayla. Really appreciate it. And now we will transition to Mariana Sears, our safety net, one of our safety net licensing managers, for an ASAM update.
Thank you, Valerie, and good afternoon, everybody. My name is Mariana. My pronouns are she, her, and as Valerie said, I'm a safety net licensing manager. I have a brief update for you all today around the transition to the ASAM criteria 4th edition. Next slide, please. All right, so we are coming back on a regular basis to meet with you all in the provider convening, and that is our intention to continue doing that into next year. And so since the last time we met at the provider convening in October, we have continued to work on focusing on spreading awareness and developing that awareness around the 4th edition changes that are anticipated for the state going forward into this next calendar year. You'll see several times in these few slides, we have the BHA laws and rules page that is hyperlinked, and I see that information is being dropped into the chat. Thank you, Shane. That is the website right now where the majority of our resources and registrations and all of that information is starting to build up, and we'll continue to build that out. So please take some time to visit that website. And if you haven't already, go ahead and bookmark it, because that's where our updated information will continue to build going forward. We've also met with the withdrawal management focused work group a couple times since we last met in October. In addition to the individuals who had opted into being part of that work group, we sent out a direct invitation to all residential withdrawal management providers. So that would be providers of ASAM level 3.2 withdrawal management services, as well as ASAM level 3.7 withdrawal management services, to make sure that they're part of the conversation often and early. As you can see here, there is an event that is hyperlinked 1126. This is present on BHA's YouTube page. We intentionally recorded one of these events so that we could use it as a good foundational starting point for providers that might be joining the discussion a little bit later. So that way we can point people in the direction of catching up, but then in continued meetings going forward, we'll all have the same foundational knowledge and be able to start with that same foundational base going forward. So if you're not super familiar with this discussion so far, and you are a residential withdrawal management provider and you're interested in catching up to the discussion, please take a minute to review, to hop over to that hyperlink on our YouTube page and review this event, just to set that base level of knowledge and catch up with us in the new year. That event focused a little bit on reviewing the provider, the options for this particular provider type going forward, which includes transitioning to a residential provider that is able to support withdrawal management, formalizing withdrawal management services into the crisis continuum, as well as potential other options for residential withdrawal management providers. So going forward, we are dedicating the month of January to intentionally outreaching and engaging crisis continuum providers in this discussion. Up until this point, we've been able to have this discussion focused on the 3.2s and 3.7 withdrawal management as that base starting point. And the second part of the impacted providers that we want to dedicate some time to catching up and aligning with are those crisis involved providers. So earlier this week, I believe actually just yesterday, an email should have gone out or will be coming to you soon if you are a crisis involved provider, particularly a walk-in crisis provider or a crisis stabilization unit. That's inviting you to join this discussion in January through a couple of events, which we'll talk about here in just a second. And then one of the other updates is we are continuing to gather information that was requested a few months ago in the transition survey that is linked in this presentation as well. We did extend the initial request for feedback was yesterday, December 18th. And that was definitely not enough time. We were hearing there's a lot of questions, a lot more information that is needed. So we have extended the requested deadline for your thoughts and feedback in that transition survey to January 15th. And made sure that that survey is editable. So we're asking that providers who are part of this impacted group take some time to look at these resources, respond in that transition survey so that we have an idea of what your questions are, what you anticipate your costs of transition might be, what you need from us moving forward. And then as things update on your end, you can go back in and edit it so we can continue to use that as a running narrative of where providers are across the state with this transition. And we're also accepting feedback, thoughts, questions, concerns, and helping fill some of those gaps by utilizing our BHA rule feedback email as well. Next slide, please. So this next slide and what the next ask is has not changed significantly from a couple months ago. The ask is still for providers to be curious and to start looking, if you have not already, at asam.org and familiarizing yourself with some of the transitions and changes that are part of the 4th edition of the ASAM criteria. The more you can look at it now and get familiar with that base foundation, the sooner we can really start working together early next year to make some of those changes that will be reflected in our rule in the most beneficial way for our state. There are resources available at asam.org that have fees associated with them, and there are a bunch of things that are free and really good high-level tools to utilize to help move you forward in that learning process. The second ask is spreading awareness to your provider networks and the community at large. Again, the Laws and Rules webpage is highlighted again here. This is where all of our information is going to be built. So please take some time on that website to look at these resources and these events. You will find that there are 2 events that are posted there and registration is open in January, one on January 13th. That one is specifically dedicated for those crisis involved providers where we would like to explore this possibility of formalizing withdrawal management services as part of our crisis continuum. Then 2 weeks after that, on January 28th, we have a larger group event, which is anticipated to be both those crisis involved providers as well as the residential withdrawal management providers in the same virtual space at the same time and talking through this possibility together. So the month of January, that's what we're hoping to focus on. And after our discussion just this very week with the withdrawal management focused work group, we are tentatively working on February of 2025 as focusing in on residential providers and the impacts of the 4th edition for residential levels of care. So we are actively working on that right now. And as soon as we have those registrations and tentative plans ready, we will have those posted on the Laws and Rules page. I believe that is all that I had to report out on. I don't think I have a closeout slide, my apologies. So I will check in as well with the provider convening team. Do we have time for any questions before moving forward?
Yes, we do have time.
Okay. Anybody have questions for me? Looking like a no. I will go ahead and also put in my direct email in case something, a question pops to mind. But I do also monitor that BHA rule feedback email along with several others that are connected to this ASAM 4 transition. So if you lose my email and you want to use that one, that's totally fine. I will most likely respond to you through that as well. Thank you for the time, and back over to you, Valerie.
Thank you so much for the update, Mariana. Appreciate that. Okay, and now we are going to switch to our two new speakers, Alex Clayton and Michelle Staley of the Criminal Justice Team.
Thanks, Valerie. So my name is Alex Clayton. I use he, him pronouns, and I am the data coordinator for the criminal justice programs. And I'll let my co-presenter, Michelle, introduce herself as well.
Hello, good afternoon. I'm Michelle Staley. I use she, her pronouns, and I am the manager for community-based criminal justice program.
So in this presentation, we're going to talk about the use of the GAIN assessment in JBBS facilities. So next slide, please. So first and foremost, we kind of want to introduce what these things are, right? The JBBS program stands for Jail-Based Behavioral Health Services, provides appropriate behavioral health services to inmates since 2011. So it's a long-standing program, at least relatively speaking. Supports continuity of care within the community after release of inmates and for people who are incarcerated. It has vast coverage across the state. So the vast majority of the counties in Colorado are the facilities in those counties utilize the JBBS program. And there are even a few counties that don't have facilities. That's when they arrest somebody, they send them to somebody else's facility. And so they're still covered by the JBBS program. So currently, I think it's 56 facilities across the state as JBBS is involved in. And that's all but maybe one or two incarceration, jail level incarceration facilities in the state of Colorado. So Michelle's going to take it away and talk about what the GAIN is specifically.
Yeah, thanks, Alex. So the GAIN stands for Global Appraisal of Individual Needs. Chestnut Health Systems is the creator. They've been around for quite some time. If you are familiar with it, you know that. What it is it's a comprehensive and standardized biopsychosocial assessment tool. You'll see different versions of this. There's multiple versions. There's also sub versions of that. We'll actually go into one of those today as we are talking about the JBBS program specifically. The other side of that is it can also be flexible. So we have created a very specific one for the GAIN that is through the LEAD program as well. So it's designed to kind of bridge that gap between clinical research and evidence-based practices. So it really does highlight a lot of the assessment tools that we are really wanting to seek out that can kind of cross-reference on that continuity of care. And we'll talk more about that in the next few slides. Next slide, please.
Yeah, so before I dive into the version that JBBS is using, I wanted to kind of present some background information about why JBBS moved to using the GAIN. And as part of the JBBS program, the program coordinators in the facilities, they have to provide assessments for people. And before, they were using 5 different assessments: one for mental health, one for substance use, one for traumatic brain injury. And if you wind back the clock even further, different facilities were using different assessments. And then they kind of tried to shore that up and said, okay, of these 5 types of assessments, you have to use one of these 2 for each category. And so one of the reasons to move towards the GAIN was because it was comprehensive, and it actually can take 4 of those 5 assessments and put it in one single assessment. So it aids in standardization across the facilities. Now, instead of 50 plus facilities using, 10 or a dozen different types of assessments, every single facility that is a member or utilizes the JBBS program uses this one assessment tool. And so it standardizes across all these different places: large jails, small jails, medium-sized jails, Western Slope jails, Eastern Plains jails, metro area, right? They're all using the same kind of assessment, which allows them to get a more standardized assessment of kind of what's going on with people, but it also allows us to get a better snapshot of what types of people are in the JBBS program, what types of people are being arrested, what types of people or what kind of issues are they encountering, what may be leading to increases in recidivism, to where people are coming back to the facility more than once. And so that was really the reason behind this shift. The requirement started on July 1st of this year with the new fiscal year. So up to June 30th, people were still kind of using different things. But as of July 1, everybody was to move towards this one single standardized assessment. What's in this version that we're using? We use what's called the GAIN Q3, which is a 3.2 light version. Again, there are multiple different versions. As a matter of fact, for the LEAD program, which is law enforcement assisted diversion, they took one form of the GAIN and edited it to meet their needs specifically. So they changed it around and moved things around to get what they really needed out of it. We identified this version as the one that kind of is the most comprehensive, while at the same time not being a massive burden for clinicians and practitioners and the program coordinators in the facilities to be using. So what are we really looking at? Well, it collects standardized background information like age, gender, race, ethnicity, school background, sexual orientation, marital status, veteran status, military background. And that's important, right? Things like veteran status and military background are not things that a lot of assessments have covered before. And as I think most of us know, right, there could be a lot of trauma involved with certain, roles in the military, especially people that are active duty in combat zones and things like that. That's not something that some of these assessments were accounting for. So it asks questions about school problems and work problems. And again, this is stuff that's not in every kind of assessment. Is somebody having issues at school, like getting to school on time or failing in school? And again, that might only apply to a small population, right? But it asks those questions. If somebody says, hey, I haven't been in school for 10 years, right, they can skip that question. It's not a big deal, but at least it's including that. Same thing with work problems, right? If somebody's having a problem getting to work on time, or keeping and holding a job, or getting a job, those kinds of things are incorporated into this GAIN assessment. It asks about things like physical health and sources of stress. It asks about risk behaviors for infectious diseases, asks about mental health, substance abuse, behavioral history, especially with crime and violence, right? What's that past experience look like? I mentioned that this is comprehensive for 4 out of the 5 assessments that JBBS used to require. The one that it does not include is traumatic brain injury. So we have another assessment that they're using for traumatic brain injury. It's very short, so it's not again, a burden for them to administer the GAIN plus a traumatic brain injury assessment. But that was one that it wasn't in the version that we're using. And one of the discussions that we're having is to add that in future versions so that everything is in one single assessment. So that just gives you an overview of kind of what are the things that are included in the GAIN assessment. Next slide, please. So what are some of the benefits for JBBS clients, for people that are using this assessment? And again, it's beneficial for the clients that are taking the assessment, right, to put this information out there. It's really beneficial for the clinicians and the treatment providers because it allows them to kind of pull this information together. So it can be administered by the clinicians, or it can be self-administered. So you can give this to the client, right, and have them go back to their cell or wherever, fill this out, and then give it back to the clinician later. So there's a lot of flexibility. You don't have to be in front of a computer. There's a paper copy of it. It's available in Spanish and English. And of course, in a state like Colorado, where we have a lot of Spanish speakers, it's really important that we had that option in there. It provides a lot of flexibility to the clinicians in the sense that, again, they could administer this in a group setting, right, and kind of hand it out and provide explanations for how to answer the questions. They could do it individually one-on-one. They can do, with a computer where they put the information right into the computer system, or they can use this paper copy. So there's a lot of flexibility with how they can administer these assessments. If it is self-administered, then those answers from the paper copy get entered into Chestnut's system. And that's one of the key pieces of this. It's not just like a paper form that you fill out. It goes into Chestnut's system. And then what you can do is you can run a report, right? You can say, okay, show me the report after somebody's answered all these questions, and it will produce, there's multiple versions. You can get like the short version that's only 1 to 2 pages, or you can get the long version that's like 11, 12 pages. And it provides a narrative explanation of how people responded to this. And it identifies issue areas like, hey, this person's really having problems with work, right? Or this person's really having problems with mental health issues or substance use or all of the above. And it'll highlight, okay, serious issue, moderate issue, minor issue, and it'll provide kind of general recommendation. Hey, monitor, this doesn't seem to be a huge issue, but make sure you'll monitor this. Or this really does seem to be an issue. You should seek out services for this individual specifically related to substance use or whatever. And so that can be really beneficial for the clinician, right? But you can also edit that report and you can use it in conversations with POs, with probation officers, parole officers, with judges, with other administrators in the facility, with other clinicians, right? So you can take out sensitive information that you don't think other people need to see. Only the clinician needs that. But you can share this report so that people might have some context for what's going on with an individual. So it's useful for the clinician, and it's useful kind of if they need to share information externally. And it does this in this easy kind of score section, right? At the very top of the report, there's a score section. We'll say, okay, this person had a 5 out of 5 for substance use, which means this is a serious issue. Whereas they had a 1 out of 5 for school problems, or they had a 1 out of 5 for mental health, or whatever it may be, right? But you can look at that score and say, okay, if somebody's 5 out of 5, this is a serious issue and we need to spend a lot of time on this, versus 1 out of 5, hey, this is something we just need to be aware of, etc. Those scores represent a risk assessment for all these different types of behavior. And these can help the clinicians determine the best potential treatment options. And I want to be really clear that it does not give specific treatment directions to the clinicians. It provides them with areas of focus and ways to kind of dial in on what a big issue may be. And then they can choose, right? Because they might know what services are available in their area better than Chestnut or even us as the BHA, right? They know what resources are available in their area or in their facility, and they can direct the clients to those resources. So it allows them to create a more customized treatment regimen, a treatment plan, instead of a one-size-fits-all approach, right? Where, okay, everybody's going to go through this and they're going to get these kind of services, or everybody's going to go through this and get these kind of services. It allows you to kind of tailor things specifically to what people's needs may be. And the hope is, with a better customized treatment regimen, we'll see better results for people who participate in JBBS. And because of that, we'll see lower recidivism. We'll see shorter sentences. We'll see less issues once they're released after incarceration. And that's the goal of the JBBS program. So next slide, and I'll turn it over to Michelle to talk about continuity, how this supports that continuity of care.
Thanks, Alex. So yeah, eventually folks get out of custody. And so one of the key factors is that reentry component of this. And so being able to have a biopsychosocial assessment that does kind of encompass the behavioral risk as well. It is not a risk assessment in the sense of risk to recidivate, but with regards to this tool for assessment, one of the things that I really found helpful, especially with this population, is that it does include that criminal justice involvement in the system. And so, again, not all biopsychosocial assessments include that. And so it was really nice to have an assessment that included that full person within the JBBS program. So what it does is it also allows for follow-up assessments for every 90 days, which is really helpful, right? To be able to compare and identify progress made, as Alex was talking about those scores. So being able to look back, look at the progress over time, 90 days, kind of that point to reference. Does this happen in the jails? Sometimes, but not always, right? This is the nice part of also being able to do that reentry level. And then focusing in on that continuity of care. So being able to have that biopsychosocial assessment as they're looking into reentry, are there things that can be started, or are there referrals that can be made as folks are getting out of custody on the front end? So having that ability to do that, and then also having a more full comprehensive understanding of what those strengths are while they're in custody, but also as that reentry. So focusing again on that reentry and continuity of care back into the community. What are the challenges they're facing and what are the needs so that they can be successful as they are reentering the community? And I will kick it back over to you to wrap us up, Alex.
Yeah, next slide to take a look at some data. So just the 2 fingers on the 90-day element, right, where you can run an assessment every 90 days. That's really useful for a couple of different reasons. One, if somebody's in the facility for longer than 90 days, you can compare to when they started in the program to where they're currently at. The other thing too is that every time somebody recidivates, they get a new, if as long as it's been 90 days, they get a new gain assessment, right? And so it's not just a one-time thing. It's okay, how's somebody doing, during this event? Then they get released, they go through the JBBS program, they get released, they successfully discharge. Now, 6 months later, they're back, right? And they get another gain assessment. And so it allows you to kind of track, okay, have things improved in one area or not? Or have they gotten worse in one area or not? Which again allows you to kind of update the services and the treatment plan that you're providing. And I think, the guidance that we're giving them is, hey, any referral that you get, whether that person has been there 5 times or never been there before, they should get a gain assessment as long as it's been at least 90 days so that you can look back on what was there before and track progress over time. So here's some nice data I put together for you. Love me some graphs. This shows the usage of the gain assessments in these facilities from June to November. Now, I mentioned that this was started as a requirement in July. So you'll notice that July, there's a lot more usage in July than there was in June. But there were people that requested access to it early and they started using it in June. So we had a few that were using it in June. Total in the last 5 months, since July, August, September, October, November, we've got 2,707 assessments, which is a fairly good number, on the average of being about 451 per month. That includes June. So if you take June out, that number is going to be a little bit higher. So the good news is we're seeing this be utilized by the jails. And you can see a kind of trend here where it kind of peaked in September and we've seen a little bit lower in October and then November. So one of the things that we've had to do is we've had to identify and really focus like what jails are really using this and which ones are not. And the ones that aren't, what's the reason for that? What's the explanation for why that's going on? And one of the things that we found is that some facilities are using it, but they're not putting it in the system, right? And if you don't put it in the system, you can't get a report to provide treatment options, right? And so it's with 50 plus jails to be able to kind of watch over, there's a lot of kind of troubleshooting as we go through. But because we're collecting all this information in a single system, I can log in every week and look at how many gains are being done on a weekly basis. And we can target facilities and say, okay, what do you need? What support do you need to be able to do this or be able to use it better? And so that's been one of the benefits. Whereas before, if they're all using these different assessments, it's really hard to kind of tell who's doing what and who's using it properly and who's not. And so this has allowed us as program managers, for Becky and Kelly as the JBBS program managers, to really focus in and say, okay, who's really doing a good job and who's not. The breakdown on the bottom, the pie chart, I think is also really useful too. This shows the percentage by jail size. So 56.1% of all gain assessments are coming from large facilities. 30% of all gain assessments are coming from medium facilities. 10% are coming from small facilities, and about 4% are coming from extra small facilities. And it defines what size facility means on the right-hand side. It's defined by the number of jail beds in the facility. But this gives, and this breaks down about how we would expect, right? As we see these large jails are using it the majority of the time, medium facilities about a third of the time. Small jails, even though the number of small jails is larger, you can see there's 19 total small jails, but the number of people that they're seeing on a month-to-month basis is much smaller, right? And then extra small jails, we have about 8 of those, but those are the ones that have 5 people in a month in the jail. And maybe one of those is a JBBS client, right? And that's really worth pointing out that not every person that goes into a jail facility is qualified or referred to JBBS. It's only a portion. And so that's what we have oversight over. And we want to make sure that the people who are referred to JBBS are getting good assessments that are useful to the clinicians, and that treatment plans are being developed using best practices from long years of research, recommendations from other clinicians and people who study this for a living, instead of just kind of doing what the clinician might think is a good idea, right? This allows us to really innovate and provide for best practices across the spectrum in all these different facilities. And so, yeah, next slide. And I think that about wraps it up for the presentation piece of things. Do we have some time for questions still?
You sure do, Alex.
Awesome. Yeah, so I'll open it up to questions about the gain or about JBBS, anything that we can answer. And our emails, both Michelle and my email are on the slide, but they're also, Shane, thank you for putting those in the chat. So if somebody wants to follow up with us, you're welcome to do that, but happy to answer any questions here and now too. Great. All right. Well, thank you so much for your time and for listening to us. And I will pass it back to Valerie for the next presentation.
Thank you so much, Alex and Michelle. Great information. And now we'll pivot to our next presenters, Callie Baker and Courtney Harrison.
Hi, thank you, Valerie. My name is Callie Baker, and I use she, her pronouns. I am a care coordinator for BHA's care coordination team, and I'm here today with Courtney Harrison, who is going to be presenting in a little bit. She is from Rocky Mountain Human Services. We're here today to talk to you about some changes that have taken place with legislation earlier this year, and to talk about the care coordination for involuntary certifications program. House Bill 22-1256 and CRS 2765-108 expanded BHA's responsibility to provide care coordination to people on terminated certifications. Providers will report terminated, transferring, or expiring certifications and indicate what the care plan will be on a provided checklist. BHA reviews the plans. If they are insufficient or if a provider has requested support, BHA and Rocky Mountain Human Services together will meet with the provider, create a needs summary, and provide care coordination. The goal for this program is to ensure a smooth transition to voluntary treatment with adequate supports in the community. Next slide, please. So prior to July 1st of this year, providers were required to report only terminated certifications to BHA. Since that time, all changes of status for certifications are to be reported to BHA prior to the termination, expiration, or transfer of that certification. We request that the report actually be submitted to BHA at least 15 days prior to the change of status. However, we do know that this is not always possible. So we ask that you, as soon as you know when the status of the certification is going to be changing, that you contact us through the form and let us know about that change of status. For hospitals, oftentimes you don't even have the individual with you for 15 days. So what we do is we ask that you will change your process so that submitting the form becomes part of the admission process as opposed to being part of the discharge process. So the change of status is reported through an online form that's been posted in the chat. And this is a secure and HIPAA compliant form for you to fill out. You complete the form, submit it to the BHA, and then we review the case for any care coordination needs. Next slide, please. All BHA care coordinators are clinicians that are licensed in the state of Colorado. We review all submissions for certifications where status is changing. We want to ensure that the individual has the appropriate and sufficient supports in place to ensure a successful transition. We being BHA, we provide the high level care coordination, while Rocky Mountain Human Services, who is contracted by BHA, provides the hands-on care management. BHA and Rocky Mountain Human Services work together in partnership and both are involved in the care review meetings for individuals entering the program. And BHA is informed of the progress of the clients throughout their time in the program. BHA care coordinators also provide support and resources to Rocky Mountain Human Services clinical care managers as needed. Next slide, please. So how do we determine the need for care coordination? There are several factors involved in deciding who might benefit from care coordination. Some examples are the acuity of symptom presentation. So this would be how the individual is presenting at time of discharge from a hospital, the prognosis of the case, that kind of thing. We would also look at the complexity of needs. For example, both mental health and physical health needs are present, and the individual would benefit from care coordination to help them navigate the systems. If there is lack of housing or housing insecurity, and the individual would benefit from further support and resources, we would think that this would be a good candidate for our program. If the individual has been hospitalized or certified multiple times, we definitely want to work with these individuals to ensure that they are transitioning out of the hospital back into outpatient treatment and are utilizing outpatient treatment so that inpatient hospitalization is not necessary again. And then, of course, if care coordination is requested, there is a specific question on the form where a provider has the ability to request care coordination for an individual. We do also ask, what kind of services you feel that person would benefit from. So there is that place on the form to request assistance. Next slide, please. If the submission indicates that there are sufficient supports in place and there are no questions, the case will be closed. BHA may get in contact with you and request more information for several reasons. First of all, if there are no supports indicated on the form, we will get in touch with you to ask why there are no supports indicated. Did that individual decline outpatient services? What's the story behind that? And would they benefit from our services to help provide more support in the community? Again, if there have been those multiple certifications or hospitalizations, we would be requesting more information regarding that, wanting to know how long of a time in between hospitalizations, what has worked in the past, what's not worked, that they keep cycling back into the hospital. And then, of course, care coordination begins if there's indication that additional support would be beneficial for that individual. And if it's requested. So we encourage providers to think about what would be helpful for their clients and request assistance for care coordination as needed. And now I'm going to turn it over to Courtney. I think I've talked enough. I'm going to turn it over to Courtney, who's going to talk to us a little bit about what happens after a case gets referred to Rocky Mountain Human Services. Courtney?
Thank you, Callie, so much. So my name is Courtney Harrison. I use she and her pronouns, and I work for Rocky Mountain Human Services as the clinical program manager with this care coordination team. So just briefly, what both you and the client get when you or the client opt in for care coordination. So if you have ever worked with community transitions within Rocky Mountain Human Services, you've worked with our team before. You have gotten that kind of care coordination. If you've worked with Momentum, the Transition Specialist Program, also known as TSP, or forensics, you've had care coordination. We are under the same CT umbrella at RMHS, and we do work in partnership with the BHA care coordinators, as Callie mentioned. So we are similar to all of the other CT programs. And just as an example, our TSP program has a 94% success rate. So working with us definitely has a lot of benefits to support both you and the clients. Next slide, please. All right, so what does our involvement look like? All of our work is completely voluntary and person-centered. This might feel a little bit confusing for our folks who are certified to receive treatment, but that's actually part of the beauty of our program is that even if they are mandated to receive care, working with us is completely voluntary. Working with us is about making their recovery look like what they want it to look like. And that's part of how we are so successful in getting buy-in, is supporting them in creating a recovery that feels sustainable for them. We collaborate on an ongoing basis with the client, the BHA, their clinical team, both inpatient and outpatient, and any natural supports. Ideally, our clients will graduate when they've completed their care plan goals that we write with them. So typically that involvement with us is 45 to 120 days. We do work very, very hard to ensure that all of our interventions are transitional in nature and are sustainable either by the client or the community. And there's my dog. He has not barked this entire meeting, and now he is barking. So I apologize. A few other things just to keep in mind as well. We do work very hard to communicate with all of our clients at a minimum of 1 time per week. It's often more than that, but we do shoot for 4 times in the first 45 days after they accept services with us. We do also complete a suicide risk assessment with our clients at least 1 time, but also on an ongoing basis as needed. You heard me mention their care plan. We do that within the first 30 days, but also re-up it every 90 days or as needed. And then also we attend their first mental health appointment either post hospital discharge or just the can to attend with them should they consent. If they don't consent to that, we will just verify that that appointment occurred. We know how important it is that there's follow-up after a major change, like a change in certification status. So and then additionally, one of the things that we're supporting with is we're actually supporting the BHA in reporting outcomes. So after our folks graduate from our program, we call and contact them 30, 90, 180, and 365 days post-program graduation to see if they're still involved with mental health care. So that is the other piece that we're working on. We've only closed a few folks out recently because we're still a brand new program. So we've only had a few with our 30-day mark so far. So still building up those numbers. But next slide, please. Okay, so there is a lot on this slide. I promise you I'll make it worth your time and I'll read it and break it down for you. So again, just to remember that it is our job to support, to build a support network with the client and for the client to utilize when their symptoms increase, rather than using crisis, emergency, hospital, or jail systems. So as Callie so eloquently mentioned earlier, the BHA care coordinators provide a macro level overview of care. Our team provides the nitty-gritty, boots on the ground, day-to-day care. So what does this look like? Ongoing communication with the behavioral health provider. That's part of why we try and go to that first meeting so that we can become a familiar face to the provider just as much as we are for the client. We're taking clients to those appointments and attending with them, supporting clients and identifying and also engaging in hobbies, vocational or educational opportunities. We're having ongoing communication with the CMA, the RAY, Social Security regarding benefits activation. We're having ongoing communication with the placement providers. Is the client sober? Are we concerned about a possible relapse? What is the status of their benefits? Are they able to pay for their stay at their assisted living, group home, sober living? If not, that's obviously a huge barrier to care. And so we want to make sure that we're supporting in that. Are they engaging in treatment? If so, awesome. What's getting them there? If not, why not? Is it that maybe they're tired of going to groups and they need to focus, they want to do some one-on-one work? Great, we can focus on that. If maybe, I've worked with a therapist who actually, he goes fishing over therapy. Great, love that. Maybe that's what we need to be doing to get a provider to engage, or to get a client to engage with somebody. Meds, are they taking meds? Have there been any issues with refills? Do we need to get a blood test? These are the things that can be really, really complicated for anybody to navigate, much less a client and much less a housing provider like an assisted living or a group home who has to do this for a lot of people. So that's something that we can help with. Are there roommate issues? Is there a conflict with a certain staff member? This is where we can also step in and provide training to providers. We work really hard to get to know our clients and really build rapport with them and know who they are as whole people, so that we can say, hey, this particular client actually really prefers to be called by his middle name, not his first name. Every time you call him by his first name, it's going to escalate him. I really recommend calling him by his middle name. We are doing any advocacy and support during outpatient treatment team meetings. I worked with the state hospitals for 9 years, and one of the things that was consistent with them was none of the clients that I served ever wanted to go into group therapy because they were doing so many groups at the state hospitals. And so one of my roles was to support the client in getting into individual services, because they had done groups like it was their full-time job inpatient in the state hospitals. So helping them advocate for services that they wanted. Weekly meetings with clients, phone, telehealth, in person as needed in the community where we need to be. Transportation support. We work with Uber Health to provide transport to any appointment that Medicaid would cover if there's an issue with NEMT. We provide bus passes, bikes, what are those, like little electrical scooters if we need to, supporting with NEMT. Sometimes it's just a matter of learning how to use it. Do we need to sit down and schedule and practice calling NEMT? Life skills support, self-advocacy, executive functioning skills, identity development, deinstitutionalization. Those are all really big, fancy words for figuring out how to live a life with a stigmatized diagnosis, right? We are in the community working with these individuals to figure out, how do I manage getting pills on 4 different kinds of medications? How do I manage getting my blood? How do I manage asking for what I need when also the voices in my head are really loud? That is my team's job, is to be there with clients, figuring it out together. De-escalation. De-escalation looks really different for every person, looks really different in every setting. So we want to be supporting there. Crucial is we are not a crisis team. All of my team is clinically trained, but they will not be responding on a crisis call overnight or on the weekends or on the holidays. They can support in a crisis, but at the end of the day, they will be referring out to a crisis team. And then any ongoing communication with contracted providers who are providing some of this wraparound care. Next slide, please. Okay, so I talked a lot about great things that we can do. But what do we need from you to make that happen? A few things upon care coordination referral to us. So after you've completed that Qualtrics form that the BHA reviews, communication about any change in certification status ahead of time. There is no such thing as too early. So what I am telling you, this is really cool, you guys. It doesn't have to be perfect, right? All we care about is the name and the date of birth. Really great. So if you think that maybe you're going to be transferring the cert, but you're not entirely sure, but you really want our services because I'm just winning you over with my personality, great. Go ahead and send that referral. But if it turns out that actually down the road, we're going to be terminating that cert rather than transferring it, that's okay. That's all right. We can handle that on the back end. What we need is the client's name and date of birth. If it turns out that, hey, you know what, we actually were thinking it was going to be transferred next week, but it's actually going to be in 3 weeks, that's okay. Let us know. The sooner we can get in and support the person, the better. Okay. You'll see here in red, communication with current providers. You all see the clients every single day and have a far better working knowledge of the client's day-to-day functioning than we do. If you know that the client gets a Haldol at 11, that's really great for us to know so we can plan not to call at 11:30. Right? These are the kinds of things that are really helpful for us to know. Contact with the client. You heard me say earlier, we are a voluntary person-centered program. We cannot serve individuals unless they opt into our services or their guardian opts into services with us. Okay, so we do need to have ongoing communication with them. And then we do appreciate any support in efforts to get ROIs signed prior to discharge. We do have a secure e-sign system to help you do that and do it quickly. But this really does help us connect with the client and their supports in the community as well. Next slide, please. All right, so what we need from you as the transition is beginning. So as that certification is transferring or the client is discharging from the hospital, whatever is coming. Information about time-sensitive needs. For example, do they need to change their address and re-register with their sex offense? Do they have a housing appointment? Do they have a Social Security appointment? Details around their plan or needs for medication. When was their last blood draw? Do they need another one? How many days of refills have they been given? If they've been given 3 days of meds refills, we can definitely help advocate and make sure they get a sooner appointment and that we're getting them in to get those refills. Contact information for the client. If you have the client's cell phone, email, address, perfect. We need all of that in the referral as well. If the client doesn't have a phone number or an email address and client is discharging to mom's cousin's boyfriend's house, cool, that's completely fine. Please give us the phone number and the address to mom's cousin's sister's boyfriend. I don't even remember what I said. And also hopefully an ROI, okay? And we can support in coordinating that as well. Any contacts that information we can get, the better. We can't support our client if we can't find them. And again, you'll see this might look a little bit repetitive. That's on purpose. The other thing we need from you is communication with the current providers. The outpatient team, the ongoing long-term team sees the clients more often than we do and have a far better working knowledge. If you know that your client actually is discharging to a house, and I have had this happen, and across the street is a meth lab, that is good for us to know. Let us know ahead of time so that we can support and do some relapse prevention planning. Okay. So next slide, please. I saw a request for contact info is right there. That is Callie's contact information and also mine. That CCIC referrals email is a general inbox. I have access to that. In addition to my clinical community liaison, she is Her name is Jess, and she's incredible. She is the one who screens through all of these referrals and makes sure they get assigned to the right person. But if she is out, I also have access to that, as do a few members of my team. So if you can reach me at either of those emails, and then that is my direct cell phone number as well, if you guys have any questions. Did I leave time for questions?
We do have some time available, Courtney.
Fabulous.
Well, it seems as though we don't have any questions, but certainly use those emails if you have any questions that come up, and we'll be happy to answer any questions that you have. And we want to thank you for your time today. We're really excited about this program and really wanted to share it with you. Thank you for having us today. And we'll turn it back over to Valerie.
Thank you so much.
Thank you very much, Callie and Courtney. Great presentation. Next slide. Okay, we just want to make sure that everyone knows that we have these provider convenings the third Thursday bi-monthly. So the next date is scheduled for February 20th, 2025. And I see Shane has dropped the registration link into the chat. We also have a BHA engagement calendar, and the link is there. And we are really hoping that folks would be willing to click on the QR code on the slide to share their feedback about these provider convenings. We would sincerely appreciate your time and effort to do so we can take that input and continue to make these provider convenings meaningful for those in attendance. Are there any other questions? Okay, I'm not seeing any, but also please stay connected with us with the BHA. You can use this QR code or go to our website or any of the social media platforms. We really appreciate everyone's attention and attendance, and we wish you all a very wonderful and safe holiday season. Thank you so much.